Lumbosacral spine, arthritis. Good morning, everyone. Today, we'll delve into the intricate world of arthritis affecting the lumbosacral spine, a region of significant importance in our daily lives. Arthritis, a condition characterized by inflammation and degeneration of joints, can manifest in various forms within this critical spinal area. Let's explore the radiographic features, diagnostic considerations, and clinical implications of this multifaceted condition. To properly evaluate the lumbosacral spine for arthritic changes, a comprehensive radiographic study is essential. The minimum recommended views include a posteroanterior, PA, lateral, and PA angulated L5/S1 spot projection. However, additional views such as anterior or posterior obliques, flexion/extension, lateral L5/S1 spot, and 25/25 obliques may be necessary to fully appreciate the extent of arthritic involvement. For the sacrum and coccyx, a minimum study consisting of AP and lateral views is typically sufficient. By carefully examining these radiographic projections, we can unlock valuable insights into the underlying arthritic processes affecting the lumbosacral spine. Our first case involves a 74-year-old female presenting with low back pain. Osteoarthritis, one of the most common forms of arthritis, can manifest in various ways within the lumbar spine. It may affect the discovertebral joints, facet joints, and even the spaces between spinous processes if they approximate. The facet joints are frequently involved, with the L4/L5 level being the most commonly affected. Similarly, degenerative changes in the intervertebral discs are prevalent, with the L4/L5 level again being a common sight. It's crucial to use the correct terminology when describing these changes, such as degenerative disc or spondylosis. Flexion and extension studies can be valuable in evaluating spinal stability in the presence of osteoarthritis. Additionally, arthritis can involve the sacroiliac joints, manifesting as diminished joint space, subchondral sclerosis, and the formation of osteophytes. To better understand the radiographic features associated with different degenerative terminology for the intervertebral discs, let's explore the key characteristics of each. A degenerative disc is characterized by a loss of disc height without a vacuum cleft. You may also observe osteophytes, often of the traction type, end plate sclerosis, and the presence of intercalary bones. In contrast, spondylosis is defined by maintained disc height with the presence of osteophytes. These osteophytes are often of the claw type, and you may also see intercalary bones. Finally, intervertebral osteochondrosis, or IVIC, presence with a loss of disc height accompanied by a vacuum cleft. Like degenerative disc disease, you may see traction-type osteophytes, end-plate sclerosis, and intercalary bones. By recognizing these distinct radiographic patterns, we can accurately classify the type of degenerative disc disease present, which can inform our diagnostic and treatment approaches. This slide showcases various osteophyte types and degenerative changes in the lumbar spine. Osteophytes, or bony projections, can take different forms depending on the underlying pathology. In the top left image, we see evidence of a degenerative disc with signs of instability, as demonstrated by the flexion and neutral views. The top right image illustrates spondylosis, characterized by the presence of osteophytes and maintained disc height. The bottom left image depicts multilevel intervertebral osteochondrosis, with loss of disc height and vacuum clefts. The bottom right image shows a degenerative disc with loss of disc height but no vacuum cleft. These visual examples reinforce the radiographic features we discussed earlier, allowing us to better recognize and differentiate between various forms of degenerative disc disease. Moving on to other arthritic conditions affecting the lumbosacral spine, we have facet arthrosis, or degeneration of the facet joints. The image on the left demonstrates facet arthrosis, with characteristic features such as joint space narrowing, subchondral sclerosis, and osteophyte formation. The image on the right illustrates Bostrop disease, also known as kissing spinous disease. In this condition, there is an abnormal approximation between the spinous processes, leading to the development of a pseudoarthrosis. While this can occur elsewhere in the spine, it is most commonly observed in the lumbar region. This slide depicts degenerative joint disease affecting the sacroiliac joint. The image demonstrates the radiographic features associated with this condition, including joint space narrowing, subchondral sclerosis, and the potential presence of osteophytes. Transitioning to our next case, we have a 58-year-old male presenting with recent low back discomfort. In this case, we are dealing with neuropathic arthropathy, a condition that can occur in the thoracolumbar spine due to various underlying causes. These include syringomyelia, tabes dorsalis, caused by syphilis, and diabetes mellitus. Neuropathic arthropathy typically presents with a hypertrophic pattern, characterized by the 6 Ds: distension, dislocation, disorganization, destruction, debris, and increased density. The image illustrates neuropathic arthropathy at the L2/L3 level, showcasing the characteristic radiographic features associated with this condition. Our next case involves a 31-year-old male presenting with low back stiffness for the past several years. This clinical presentation raises suspicion for ankylosing spondylitis, a chronic inflammatory condition primarily affecting the axial skeleton in males. Ankylosing spondylitis is characterized by articular ankylosis, ligament ossification, and enthesopathy. It commonly affects young males between the ages of 15 and 35 and has a male-to-female ratio of 4 to 15 to 1. Approximately 50% of patients with ankylosing spondylitis will develop large peripheral joint involvement, while 30% will experience small peripheral joint involvement, commonly affecting the hips, shoulders, knees, and heels. Patients may experience regional pain, decreased range of motion, muscle atrophy, and joint contractures. Low back stiffness is a common presenting symptom, and extraskeletal manifestations can involve the eyes, heart, vessels, chest, and gastrointestinal/genitourinary systems. Laboratory findings may reveal an elevated erythrocyte sedimentation rate, ESR, during active disease, and approximately 90% of patients will be positive for the HLA-B27 antigen, which is present in only 6 to 8% of the general population. Additionally, rheumatoid factor, RF, is typically negative in ankylosing spondylitis. Radiographically, ankylosing spondylitis often presents with bilateral and symmetric involvement, along with osteoporosis. In approximately 60% of cases, the first signs appear in the thoracolumbar spine, while the remaining cases may initially manifest in the sacroiliac joints. When evaluating the sacroiliac joints, the hallmark feature is bilateral symmetric involvement. Changes are often more severe on the iliac side due to the presence of less cartilage compared to the sacral side. The radiographic progression of sacroiliac joint involvement can be categorized into 3 stages. Stage 1, pseudo-widening due to subchondral bone resorption. Stage 2, erosions and sclerosis, resulting in the characteristic rosary bead appearance. Approximately 40% of cases may resolve at this stage. Stage 3, ankylosis, where a hint of the sacroiliac joint may still be visible, referred to as the ghost joint. Around 50% of cases progress to complete ankylosis at this stage. The upper sacroiliac joint ankylosis can give rise to the star sign, which is not specific to ankylosing spondylitis and can also be seen in diffuse idiopathic skeletal hyperostosis, DISH. Continuing with the radiographic features of ankylosing spondylitis in the spine, we may observe erosion of the vertebral body corners, known as the Romanus lesion. Squaring of the vertebral bodies anteriorly. The shiny corner sign, where the eroded corners heal, appearing dense and shiny. Ossification of the outer annular fibers, forming syndesmophytes. Marginal syndesmophytes originate at the vertebral margins and are the most common type. When multiple segments are involved bilaterally and symmetrically, it creates the classic bamboo spine appearance. Non-marginal syndesmophytes originate from the mid-body of the vertebrae. The images on this slide showcase examples of sacroiliac joint involvement at different stages, as well as the characteristic spinal changes seen in ankylosing spondylitis, such as the dagger sign, trolley track sign, and railroad track sign. Moving on to our next case, we have a 38-year-old female presenting with low back pain for several months. This clinical scenario raises suspicion for osteitis condensans ilii, an isolated sacroiliac arthropathy with a controversial origin. Osteitis condensans ilii predominantly affects multiparous women between the ages of 20 and 40, with a female-to-male ratio of 9 to 1. These patients typically have positive orthopedic sacroiliac joint tests and experience pain that resolves quickly after adjustments. Interestingly, laboratory findings are usually normal, which can make it challenging to differentiate osteitis condensans ilii from other conditions such as seronegative spondyloarthropathies like ankylosing spondylitis and osteoarthritis. Radiographically, osteitis condensans ilii is characterized by a triangular sclerosis of the ilium adjacent to the sacroiliac joint. This sclerosis may be unilateral or bilateral. Notably, the sacroiliac joint itself often appears normal, without any evidence of erosions or joint space widening. The sclerosis can regress over a period of 3 to 20 years. The images on this slide demonstrate unilateral osteitis condensans ilii, with the characteristic triangular sclerosis adjacent to the sacroiliac joint. While we have covered several arthritic conditions affecting the lumbosacral spine, there are numerous other disorders that can involve this region. These include degenerative and related disorders, Diffuse idiopathic skeletal hyperostosis, DISH ossification of the posterior longitudinal ligament, OPLL ossification and calcification of other spinal ligaments. Ligament calcification and ossification of the sacroiliac joints. Inflammatory disorders. Rheumatoid arthritis. Enteropathic arthropathy. Psoriatic spondyloarthropathy and reactive arthritis. Crystal/metabolic disorders. Calcium pyrophosphate dehydrate crystal deposition disease. Alkaptonuria. Gouty arthropathy. Hyperparathyroidism. Renal osteodystrophy. While we did not cover these conditions in detail during our class, it is essential to be aware of their existence and potential involvement in the lumbosacral spine. The images on this slide provide examples of some of these conditions, further emphasizing the diverse range of arthritic and arthritis-related disorders that can affect this critical region of the spine. That concludes our exploration of arthritis in the lumbosacral spine. I hope this presentation has provided you with a comprehensive understanding of the radiographic features, diagnostic considerations, and clinical implications of various arthritic conditions affecting this region. Remember, a thorough knowledge of these entities is crucial for accurate diagnosis and optimal patient management.